Hello, I'm Mark Yeaser from the Universities of Pittsburgh, Southern Denmark, and Tel Aviv. And in a few moments, I just want to give you an update on the use of whole blood in trauma, as well as some other new things in transfusion that you might not have seen in the literature. Here are some disclosures that you should know about. These are the results of a survey that we just recently did looking at level 1 trauma centers in the USA. And you can see that the use of low titer group O whole blood in resuscitating trauma patients, those are the black bars, has really been increasing since 2018. That's when the AABB, the transfusion regulatory body, changed its rules and allowed the use of low titer group O whole blood to be used for patients whose blood type is not known at the beginning of the resuscitation. And you can see that also the use of group A plasma has really been increasing over the past few years because it's so difficult to maintain an inventory of AB plasma, which is the universal donor, that many centers have just started to use group A plasma, which will be compatible with about 85% or more of the recipients who are either group A or group O. But it's just that we don't have enough AB plasma, so we administer group A sometimes. And so you might be concerned that some patients are going to hemolyze. That means when we give them group O whole blood that has anti-A or anti-B in it, or group A plasma that has anti-B, if those antibodies bind to the recipient's red cells, it can destroy them. Luckily, that's not what we're seeing. So here's some new data from Pittsburgh, our latest data on the use of whole blood, where these recipients are all trauma patients who received at least 4 whole blood units. And then we measured the biochemical markers of hemolysis, which are not specific for hemolysis, but they're sensitive to it. And you can see in terms of the haptoglobin and LDH, there was no difference between the group O recipients who would not hemolyze from getting group O whole blood and the non-O recipients. Those are the B, A, and AB recipients who could hemolyze, but they're not. When you look at the total bilirubin, you can see that there were some statistically significantly higher values on day 1, 2, and 3 amongst the non-O recipients, but the values are still not outside of the reference range. They're still well within the reference range, and there were a few very sick non-O recipients who had very high total bilirubin concentrations, which I think is skewing the results. So we interpret this as no evidence for hemolysis. We also did the study in our pediatric recipients of whole blood, and you can see here that when we use a titer of 50 for our pediatric patients, again, all trauma patients, all getting between 20 to 40 mils per kilo of whole blood, you can see no difference whatsoever in any of the biochemical markers of hemolysis, including the total bilirubin, which indicates that these patients, although small, when they get a weight-appropriate dose of whole blood, they don't hemolyze either. And in fact, we've since increased our titer threshold for the kids to less than 100 based on this good data that shows that these patients aren't at all hemolyzing. You might ask the question, well, the patients aren't hemolyzing when they get incompatible plasma, but are there other effects that they might be experiencing, such as increased mortality? So we did a study where we looked, retrospective study, where we looked at group A recipients of group A plasma in trauma and group B and AB recipients of group A plasma. These are the patients in the incompatible group who might experience hemolysis, and they received about a median of 1 liter of incompatible group A plasma during their resuscitation. And when we compared these two groups of patients, you can see no difference at all in hospital mortality or early mortality, or in fact in terms of the hospital length of stay. And when we did the logistic regression, we found that getting incompatible group A plasma was not a significant predictor of in-hospital and 24-hour mortality. We did another retrospective study where we looked at all types of incompatible plasma, not just group A plasma, but any type of plasma from all sources that could be incompatible amongst about 1,300 trauma recipients who received only compatible products, and about 1,300 trauma patients who received at least 1 dose of incompatible plasma products. And we asked the question, is there any difference in 6-hour, 24-hour, or 30-day mortality. And you can see, because all of the confidence intervals overlap 0, that there was no difference in survival at any of these relevant time points for the patients who received incompatible plasma. So this shows that it's safe to use Group A plasma in your trauma patients and Group O whole blood, and that's a good thing because the use of these products is greatly increasing in the U.S. What about outcomes? There is a new and evolving literature comparing trauma patients who received whole blood to those who are receiving component therapy. And we just submitted a very large review of all of the studies that have compared outcomes in whole blood patients compared to conventional component recipients. And you can see these are the results for mortality. Some of the studies showed a significant survival improvement in the emergency department for whole blood recipients. Others showed that the whole blood recipients had worse survival in the emergency department. But either way, whether these whole blood patients survived better or worse, by the time 24 hours or overall mortality came along, that difference was gone. Some studies, again, have also shown significant differences, improved outcomes for the whole blood recipients at various other time points. But again, it's a small literature, generally retrospective studies, not a lot of patients in each of these studies. And so we have to take all of this with a grain of salt. Nevertheless, it's all pointing in the same way, that whole blood is not causing increased harm to our patients. When we looked at other clinical outcomes, sepsis, clots, kidney failure, that sort of thing, most of the studies found that there was not a significant difference between the whole blood recipients and the component recipients. So again, this is all good. Having a closer look at some of these data here, we have a propensity match study that we did in Pittsburgh amongst adult recipients who received at least 4 whole blood units during their trauma resuscitation. And we looked for everything we could think of, including different mortality parameters, length of stay, days on the ventilator, the MODS, kidney injury, etc. We couldn't find any differences whatsoever in these amongst these recipients. Again, it's a small study, 92 propensity match patients, but no difference whatsoever between the two groups. And then we did this again in children, and again we similarly found when we compared 36 whole blood resuscitated children to 36 patients children who received conventional components in their resuscitation. Again, no significant difference in any of the outcomes, or except perhaps in the ICU length of stay, which favored the whole blood patients. So again, it's all pointing in the same direction, that whole blood certainly doesn't make things worse for the recipient, and it might make it a bit better, such as in this study here, which I thought was a really good idea that my colleague Christine Leeper had. She asked the question, so simple, she asked the question, how long does it take to get 1 unit of plasma, platelets, and red cells if you're getting whole blood or if you're getting components? Now, this is at our children's hospital, and we have a massive transfusion protocol at the children's hospital, so when it's activated, plasma, platelets, and red cells come very quickly. But look how long it actually takes. If a patient gets whole blood, that's the black line, they're basically instantly getting balanced resuscitation. But the dashed line are the patients who are resuscitated with components, and you can see that sometimes it takes hours to get just 1 unit of plasma, platelets, and red cells. And we know how important balanced resuscitation is early in the resuscitation effort. And if you're using components, even if they're very quickly available to you from the blood bank, it still takes time to administer them. Yet with whole blood, the balanced resuscitation is instant. Furthermore, in children, we showed in a propensity match study of whole blood recipients versus conventional components that the median time to correction of the base deficit was a 4-hour difference between the whole blood patients, that's the solid line, and the dashed line are the conventional component patients. So the base deficit corrected faster without a penalty of increased hospital death, disability, or length of stay. None of that was different, except that the base deficit corrected faster in the whole blood group. There are many other advantages of using whole blood. It makes the resuscitation so much easier, as we saw. As soon as you start giving whole blood, it's balanced resuscitation in one bag. Whole blood is more concentrated than components because you avoid the additive solution that comes with every red cell, and that's 100 milliliters of a saline-based solution that doesn't transport oxygen or cause clots or promote hemostasis. So that's what that's an advantage of whole blood. Of course, whole blood contains cold stored platelets, which are primed and ready for hemostasis, which is a new area that is being researched quite intensively. Similarly, along with the cold stored platelets, there's a reduced risk of bacterial contamination because now we're keeping the platelets in the cold, not at the room temperature. Platelets now available where they might not have been. You normally wouldn't put platelets in a small hospital that wouldn't transfuse them regularly, but if there's whole blood at that hospital, then platelets are available by default, and you can store them now for 21 or 35 days rather than the old 5 or 7 day storage for room temperature platelets. If you're giving Group O whole blood, it's reducing the risk of a missed transfusion, which is giving the wrong ABO type of blood to the patient. That can be a lethal event. And for pre-hospital transfusion, it's much easier to transport whole blood than it is to take plasma and red cells with you, and it reduces donor exposures as well. At the moment, there are no reported randomized controlled data for platelet replete whole blood for trauma patients. We don't have any of these RCTs yet. A small pilot study has been completed at Pittsburgh, and we're eagerly awaiting the results of the POWER study. There are two randomized trials that are either underway or shortly to be underway, one in the USA, one in France. The American trial will start with whole blood in the pre-hospital setting, continue through the hospital course. And the same thing is similar in France. Whole blood versus conventional components, and the primary outcome of the French study will be the thromboelastogram parameters. And so in conclusion, there's no evidence for hemolysis of when patients are getting moderate doses of whole blood. And as we saw, getting Group A plasma or whole blood doesn't lead to premature death. Whole blood recipients generally don't do worse than conventional components, and sometimes they do better. And it's a very easy and convenient product to use that's being used increasingly in the USA. Thank you very much.